Hello, everyone, and welcome to the TMA's Ask the Expert podcast series. Today's podcast is entitled Rheumatological Conditions with ADEM, NMOSD, TM, and OM. I'm Sam Hughes from the Neuroimmunology program at UT Southwestern Medical Center in Dallas, Texas, and I'll be moderating this podcast today. The TMA is a nonprofit focused on the support, education, and research of rare neuroimmune disorders. You can learn more about the TMA on the website at myelitis.org. This podcast today is being recorded and will be made available on the TMA website for download and for download via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. For today's podcast, we are pleased to be joined by Dr. Julius Birnbaum and Dr. Tracy Cho. Dr. Birnbaum graduated magna cum laude from Princeton University and received his MD from Columbia College of Physicians and Surgeons. He earned his master's degree in clinical investigation at the Johns Hopkins Bloomberg School of Public Health. Dr. Birnbaum is the only physician in this country who is board certified in neurology, internal medicine, and rheumatology. His clinical and research interests pertain to the neurological complications of rheumatic syndromes with a focus on Sjogren's syndrome. Dr. Tracy Cho is an associate professor of neurology at Harvard Medical School and director of the Autoimmune and Infectious Neurology units at Massachusetts General Hospital. He focuses clinically on meningitis, encephalitis, and myelitis due to infections such as HIV and cysticercosis, as well as neurological complications of systemic medical diseases like sarcoidosis and lupus. He also specializes in autoimmune neurological disorders such as NMDA receptor antibody encephalitis and other antibody-mediated encephalitides. Welcome, and thank you both for joining us today. So before we dive into the questions that came from the community, I kind of wanted to set kind of a foundation for us as we start this conversation. Speaking for myself as a non-physician, when I started into this world of immune-mediated conditions, it was certainly a little bit confusing to me to be talking about rheumatologic conditions versus immune-mediated conditions, and then central nervous system disorders that are immune-mediated, and autoimmune disorders. And there was a lot of vocabulary that kind of meshed together and was slightly confusing for me, at least. And so I'm hoping that we can kind of, like I said, lay a foundation with kind of general definitions of what, when we talk about rheumatologic conditions, what do we really mean? Is that the same as autoimmune disorders, or where are they different? And then why are disorders like neuromyelitis optica spectrum and transverse myelitis and other neuroimmune disorders maybe not considered rheumatologic conditions? Kind of where one ends and the other begins. So if you could, Dr. Birnbaum, I'll throw it over to you if you just kind of want to give us a little bit of an overview and foundation of what we talk about, what we mean when we talk about these disorders.
Sure. So thank you for having me. I agree with you that a lot of the terminology that's used in clinical medicine to categorize these disorders can be confusing. The unifying feature of all these disorders is that the immune system, which should be protecting us from infections and cancers, starts acting aberrantly, and this can result in different diseases. So when we think broadly of the field of rheumatology, there's two facets to it. First, these are disorders which we regard as being musculoskeletal, so that could be pain in shoulders or back of uncertain origin, and those, such as osteoarthritis, who we consider to be not mediated by autoimmune disorders. So for example, osteoarthritis is more wear and tear, but the immune system is not acting aberrantly. The other hat of rheumatology does deal with autoimmune disorders. The unifying feature of these autoimmune disorders, which make them rheumatological disorders, is that they are associated with so-called systemic manifestations. So for example, when you think of a rheumatic disorder such as Sjogren's and lupus, these are autoimmune disorders, but in different patients, different organs can be affected. So this can include the heart, the lung, the kidney, and the skin. Now, neurological disorders can occur in subsets of patients with rheumatic disorders. So again, I would define rheumatology as the practice of two facets. One is what we call musculoskeletal disorders, and one is autoimmune disorders. And the rheumatological disorders broadly can affect many, many different parts of the body. And when we have autoimmune neurological disorders occurring in patients with rheumatic diseases, the issue is what we call attribution. So specifically, is a neurological disorder specifically due to rheumatic disorder, or is the neurological disorder just presenting as a coincidental and secondary unrelated diseases? So hopefully that provides some sort of vista of what constitutes rheumatological disorders and what constitutes neurological disorders and how they relate to each other.
Mm-hmm. And I think so our community who's listening to this have by and large been diagnosed with one of these rare neuroimmune disorders, NMOSD, TM, ADEM, that aren't really considered rheumatologic conditions. They're considered neurological conditions that are immune in origin. And then there are sometimes those patients who have Sjogren's or lupus that then, like you were saying, have a neurologic manifestation that we call a transverse myelitis or some kind of a brain or optic nerve lesion associated with it. So we consider these, and please correct me if I'm wrong, either of you, neurologic disorders if they are, even if they're autoimmune in nature or immune-mediated in nature, if they are focused on the nervous system, either central or peripheral, as opposed to maybe these rheumatologic conditions like a lupus or sarcoid that affect other organs, and then in a rare subset of patients also affect the central nervous system. Am I understanding that properly, or would you describe that differently, either of you, Dr. Birnbaum or Dr. Cho?
I'm happy to.
Go ahead, Dr. Cho. Yeah.
Thank you. So I agree with Dr. Birnbaum's framework as laid out. I guess I would, to address your question, I think we need to step back and define transverse myelitis, which is a syndrome. It can be due to many different diseases, whereas neuromyelitis optica is a specific disease due to a specific pathologic antibody which has a target within the central nervous system. And likewise, ADEM is also a syndrome, but it lies somewhere in between the transverse myelitis term, which is quite broad and can be due to multiple different diseases. And in MO, where it's such a specific diagnosis, ADEM is somewhere in between in that it is defined by typically an acute one-time episode of inflammation that from a trigger firing the immune system to target the myelin. So in regards to the framework that Dr. Birnbaum laid out, if someone with lupus develops transverse myelitis, there is the question of whether the myelitis is attributed to the lupus or whether the myelitis is due to a separate process. And as the topic for this webinar and many of the questions submitted suggest, there is a well-established link between NMO and other autoimmune diseases that affect other parts of the body. And I think one of the sort of key points that we're going to get to today is whether NMO is indeed part of that broader systemic autoimmune disease or whether it is a separate disease, and with the latter being my take on the question of NMO. So the terminology really is confusing, as you both have stated already, and I think that we need to be precise when we're talking about the attribution of transverse myelitis when we have a clear cause, such as an NMO, versus when we're unsure of the exact cause before we can say whether or not it is related to a systemic disease process.
Mm-hmm. Yeah, that's like we've been talking about. It can get pretty complicated, and I think from the conversations I've been a part of and observed, even with the clinicians and researchers talking, a lot of these conversations occur just trying to define what everybody's saying, what they mean when they say it. But it kind of moves into, especially Dr. Cho, like you were saying, are patients who are diagnosed with NMOSD in particular. What we see in many cases is also an increased risk of what we call, comorbid rheumatologic conditions, or these rheumatologic disorders that happen at the same time that we don't think are related to the NMO. And without getting into, all of the genetic underpinnings of why we think autoimmune disorders are connected, as we're, researchers are still working out, could Dr. Cho, could you maybe speak a little bit to why we think that this comorbidity occurs with autoimmune disorders, and then what really are those rheumatologic conditions that we do see associated with these rare neuroimmune disorders like NMO spectrum disorder?
Sure. So the underpinning, I think, is, like you mentioned, in generic terms, a general tendency for the immune system to attack self as opposed to cancer or infection, as Dr. Birnbaum pointed out in his framework. And so it's well known that some patients with a certain autoimmune disease have increased risk for other autoimmune diseases, and it just varies from individual to individual how that manifests in terms of the specific diseases they get and what parts of their body are affected. So it's kind of a blanket statement, but certain autoimmune diseases tend to run in packs, and so if you have one, there's a slight increased risk of having one of the others on the list. And for NMO spectrum disorders, the most common associations are indeed with lupus and Sjogren's syndrome, but there are many others that have been associated with increased risk, and it goes in both directions, meaning someone who develops NMO as their first disease could later develop and be diagnosed with a systemic autoimmune disease, or someone who has a known autoimmune disease like lupus has a slight increased risk in developing future NMO. And the associations are not well laid out in terms of the exact mechanisms, and we're not very good at predicting the exact risk associated, but those are the two most common. I also think that we will learn more about this as we better define the underpinnings of these different autoimmune diseases in terms of specific genes. Some of that is in the works, but I think we've got a long way to go on that front.
So back to you, Dr. Birnbaum. There are some questions that came in that are still kind of broadly about rheumatologic disorders. Like Dr. Cho was saying, there are some conditions that are associated with NMO and these disorders that our community lives with. But how are these different rheumatologic disorders like Sjogren's or lupus or rheumatoid arthritis even diagnosed and treated? And then how are those treatments, how do they differ or are similar to the immune treatments that we see for the recurrent neurologic disorders like NMO?
So, another good question. The rheumatic disorders basically are defined by a combination of patient's symptoms, what we find on the physical examination, and blood markers usually, and these blood markers usually confirm in some way the presence of autoimmunity. So there are disorders such as lupus, which have protein symptoms, and the diagnostic net is quite wide. But by and large, there's certain cardinal features of, for example, skin manifestations such as lupus. I think everyone is familiar, most of us are familiar with a butterfly rash. And then it's, again, trying to go through different organ systems, tease out different diseases. So again, lupus, many different organ systems are affected. So we would ask, for example, is there hair loss? Is there, or are there ulcers in the nose or the mouth? Is there episodes of when you take a big breath, it hurts too much, or when you lie back, there's pain in the back, and that could indicate inflammation in the lining around the lungs or the heart. Any history of kidney stones, any history of blood in the urine. So these are symptoms that could affect different organs that we try and tease out. And then there's a physical examination, and generally we inspect hair texture, hair loss. We look in the mouth. If it's Sjogren's, we are looking at whether there's adequate saliva in the mouth. We'll listen to the lungs. We'll want to evaluate whether there's something called a rub, which is grinding of lung or heart against different parts of the body. Joint manifestations are a particular calling card of different rheumatic diseases. So we'll look at the knees and the elbows, the knuckles. We'll squeeze and evaluate for any tenderness. We'll see whether there's any swelling of the joints. So hopefully this is just to illustrate in a compelling way of how many different things that we need to assess in the rheumatic diseases. But based on that, we have a formulation, and we're able to siphon down to a few set of symptoms and examination findings. And then we look at the blood work. And by and large, there are certain abnormalities that are associated with diseases. So lupus might be associated with a very specific panel of antibodies, and same as rheumatoid arthritis. So again, at the end of the day, it's the patient's symptoms which matter the most, and the history is the most illustrative and informing feature. The rheumatic disorders, interestingly, are treated with some immunomodulatory agents that are similar that are used for transverse myelitis. So transverse myelitis, by and large, you want to suppress the immune system. So that paradigm of suppressing the immune system is similar to some rheumatological disorders. There's also a subset of treatments which are called immunomodulatory disorders, and these are medications which don't necessarily suppress the immune system, but it modulates the immune system and behaving in a more tolerant way. Those classes of immunomodulatory medications tend to be more specific for rheumatological disorders as opposed to transverse myelitis. So example, immunosuppressive medications, and that might include something called rituximab or methotrexate or Cellcept. Those are medications that are shared between rheumatic and diseases, neuromyelitis optica, sometimes ADEM. But certain of the immunomodulatory medications are more specific and have a specialized niche in rheumatic disorders and are not more widely used in transverse myelitis. So again, some areas of overlap in terms of disease manifestations and treatment, but also some areas in which medications are specific for rheumatological versus transverse myelitis.
Mm. So kind of as a follow-up to that question, when we were talking about NMO spectrum disorder patients, you know, the most common medications that they're on to prevent relapses are, like you mentioned, Rituxan, Cellcept, and even Imuran from time to time. So would you say that if I'm an NMO patient and I then go on to develop Sjogren's or lupus or some other rheumatic condition, and I've been taking Rituxan or one of these other medications, would you, as a rheumatologist, seeing that, say, we're going to keep, what you're on, what you're taking for the NMO covers this other disorder, and so we'll move forward with that? Or what circumstances would you look at a patient with a long-standing diagnosis of one of these neurologic disorders who develops a rheumatic condition and say, we need to work with your neurologist or add another therapy, that kind of thing?
Yeah, so that's an interesting question. I think that if you have a rheumatic disorder that's breaking through a medication that you use for Rituxan, what you're doing is exactly correct. You have to think about whether that leads to abortment of treatment for the transverse myelitis, or whether you want to keep that medication on board. And I think a lot of it depends upon the severity of the rheumatic disease flare. So if you're diagnosed with new rheumatic disease, and it tends to be what we call musculoskeletal natures and joint manifestations or sores in the mouth, I think then you'd try to keep the immunosuppressive agent for Rituxan on board, and it could be treated, the rheumatic manifestations could be treated with short courses of steroids and managed in an expectant way. In other cases, if there's severe disease manifestations, heart, lung, kidney, then you would need to start medications that are specific and effective for those rheumatic diseases. And in those disorders, you would try to see whether you could come up with a regimen that would also be useful for minimizing risk of relapse in transverse myelitis. And sometimes we add to immunosuppressive agents when necessary. It wouldn't be the first step because of the risk of infection, but in situations in which you're kind of trapped in a corner, we have used 2 combinations of immunosuppressive therapies, both successfully and also with a tolerable risk of minimizing infection. So it depends upon the severity of the flare and what that rheumatic disease is.
Yeah, and that kind of moves into some other questions that came up about kind of this potential drug-drug interaction, for lack of a better term, with these immune agents. So I guess first question is, like you said, Dr. Birnbaum, many of the rheumatic conditions that can be comorbid with NMO can be managed by the same immune medications. Is there any rheumatic disorder that you might expect to see or would not be surprised to see manifest in an NMO patient that would require one of these more specific immunomodulatory agents that's used in the rheumatologic world that we don't necessarily see in the NMO world? And if so, do you kind of go into more detail about concerns you might have about these interactions of medications?
So you're saying, are there specific immunomodulatory medications normally used for NMO that used for rheumatic diseases that might be useful for NMO? I just want to make sure.
Well, useful, or really even if there's a condition that's diagnosed alongside the NMO, rheumatic condition diagnosed alongside the NMO, that normally would have a different, not Rituxan or Cellcept or Imuran medication used for it. Is there concerns about kind of the safety, like you were getting at before, of multiple immune agents used at once?
So it's interesting. There is a widening net of therapies that might be useful for NMO and is used for rheumatic diseases. So, for example, the medication Actemra, tocilizumab, which is approved by the FDA for the treatment of rheumatoid arthritis. It's being investigated for efficacy in NMO and has been shown to greatly reduce neuropathic pain in NMO. So there is a reason to think that certain immunomodulatory medications that are just currently approved for specific rheumatic diseases might be more ubiquitously effective for NMO, and this is certainly a fertile area for research. When you combine two immunosuppressive medications, you do incur the added risk of an infection. But the point that I'd like to illustrate is that there's other autoimmune disorders, such as inflammatory myositis, when there's inflammation in the muscles. A subset of these patients could develop really debilitating and severe lung disease. And in these patients, 2 or 3 immunosuppressive agents are used, and there's a risk of infection, but I think at the end of the day, it needs to be geared and towards how severe the disease is. And I think one thing to emphasize is a lot of times when patients are on immunosuppressive therapy, there's a concern, can I go near my daughter? And I think that when we use immunosuppressive therapy, we are not completely knocking out the immune system. We're not treating it as chemotherapy. You still have an immune system that hopefully is effective in fighting off infections. So I would say that you want to try immunosuppressive monotherapy if you can, but when you need to use multiple immunosuppressive agents, you still have an immune system, you still have the ability to some extent to fight off infections, and when it's necessary, it needs to be tailored towards the aggressiveness of the rheumatic disease.
I think that's a good point. I'm going to turn over to you, Dr. Cho. Dr. Birnbaum and I have been talking for a little bit now. There's a number of questions.
I have one thing to add to that topic before you leave it.
I
don't know how many of your members have a possible diagnosis of MS. That's often on the differential for transverse myelitis. And as some providers offer MS medications for patients whose only manifestation is transverse myelitis, I would just add that the interferons that are used, the injections that are the sort of traditional first-line medications in MS have been known to exacerbate or worsen or cause a flare-up of some underlying autoimmune diseases or rheumatic diseases. So those medicines, I've had a few patients that I've seen after they were seen by my MS colleagues, and we ultimately used medicines like Dr. Birnbaum mentioned, like mycophenolate mofetil, that might be beneficial for both MS or lupus to avoid the risk with the interferons. So I think it does bear mentioning that some of these medicines, both for neurologic and non-neurologic diseases that can activate the immune system, sometimes, rarely, can trigger a flare-up of an underlying autoimmune disease, and we try to avoid those in those situations.
Yeah, I appreciate that point. I think, especially in the NMO world, I think it's been made pretty clear in the literature that the interferons, like you said, that are used in first-line MS meds, exacerbate the NMO disease process. And there are certainly those patients who were diagnosed, before the advent of the NMO antibody that were treated like MS and had worse disease after that. So I think in our world we think about MS, interferons worsening NMO, but we don't necessarily think a lot about if the transverse myelitis is from an underlying rheumatic condition, that the interferons normally used in multiple sclerosis might even exacerbate those conditions. Am I understanding that properly?
Yes. Even when it's due to MS, I would not use MS, interferon specifically, if they have an underlying rheumatic disease like lupus.
Yeah. And so sticking with you, Dr. Cho, there's some of the questions come in kind of relate to each other in this way. I think globally, when we talk about rheumatic conditions and these rare neuroimmune conditions, patients kind of fall into two categories. There's those who have some kind of rheumatologic condition, and then they develop a neurologic manifestation of that disease, like a transverse myelitis, or they're then diagnosed with NMO that is occurring alongside their lupus or whatever. And then there are those patients who have transverse myelitis, and they're treated like say, basically an idiopathic transverse myelitis. And then a couple years later, they develop a rheumatic disease process. And then there's the question that the patients have that come up, where is my TM, was that really a one-time event? Was that the first manifestation of my lupus or my inflammatory arthritis? And should I be worried about reoccurrence of my neurologic conditions? I think that this is a big unknown with that kind of subpopulation of our patients, specifically the TM patients, who for a few years have been told that this is an idiopathic one-time event. Now they have some kind of rheumatologic condition, inflammatory arthritis or what have you, and the fear of the unknown that they might have another attack of TM. Could you speak a little bit to kind of how you as a medical provider look at that kind of case and how you monitor it?
Sure. So that is a great question, and I guess the starting point for me would be, what was the nature of the transverse myelitis? And I think of certain big buckets or categories. In patients who have a partial transverse myelitis that is only affecting one or two segments of their spinal cord, if the first question is, do they have any other indications that they might have multiple sclerosis or be at high risk for developing multiple sclerosis? And I think that pathway is well recognized by neurologists, and it's kind of a routine workup when patients present with, so the categories there would be a idiopathic transverse myelitis with no other indications of MS, and those patients are at relatively low risk for having a recurrence. Whereas the patients who have any indication that they've had prior MRI findings that are suggestive of MS, even if they hadn't had symptoms, those patients are at high risk for developing MS.
Yeah.
When the lesion is larger, the transverse myelitis lesion is a longitudinally extensive lesion that is classically more compatible with NMO, then the sort of predictive algorithms are different, and we know that patients who have the NMO antibody are at high risk for recurrence. Now, when I see patients who have any kind of myelitis, whether it's short or long, I check for the NMO antibody as well as the myelin oligodendrocyte glycoprotein, or MOG antibody, which can sometimes mimic NMO. And if those are positive, then those patients bear treatment to prevent recurrence because we know the recurrence rate is high. If those antibodies are not present, then it's a judgment call on the part of the patient and the physician about what the risk of recurrence is and whether they need to be on an immunomodulatory agent or immunosuppressive agent to prevent a recurrence. So in the patient that you're describing who has a prior transverse myelitis with a presumably negative workup for other signs of MS or antibodies for NMO, who later develops symptoms and signs of an autoimmune rheumatologic condition, my immediate concern would be that the patient has NMO because of what we discussed earlier with the high rate of co-occurrence of NMO with other autoimmune diseases. And I would look hard, again, as we know the NMO test is not perfect. Sometimes on repeat testing it becomes positive. And so it's not that having another autoimmune rheumatologic condition guarantees that you're going to have a recurrence if you've had transverse myelitis, but I think it would make me suspicious enough that I would look again for NMO. And if it's still negative, then I think it's, again, a gray zone that requires judgment from the patient and physician on a case-by-case basis, and also depends on how severe the nature of the rheumatologic symptoms are in terms of whether to treat. So that's kind of a vague answer. I think it really depends, the risk for recurrence really depends on the nature of the original myelitis and whether it was a long segment or a short segment, whether there was any signs of MS, obviously whether the antibodies for NMO or MOG were present. And my personal general take would be to follow those patients carefully for any development of other neurologic symptoms and have a very low threshold for treating them for recurrence.
Dr. Birnbaum, would you have anything to add to Dr. Cho's statement?
Well, yeah, the one thing I would think about is there's always these questions about when someone has myelitis, and for the most part, be it like transverse myelitis or ADEM or neuromyelitis optica, as Dr. Cho was saying, is the questions like, what's the relationship to the underlying rheumatic disease? And I think the understanding of this relationship has greatly changed over time. So, for example, in the 70s and 1970s, 1980s, MS, multiple sclerosis, and lupus were thought to have a similar mechanism, and so that led to the term combined together called lupoid sclerosis. And I think that the treatment back then of MS and lupus went hand in hand. What we're recognizing now is that the disorders that we see, be it NMOSD, neuromyelitis optica, or ADEM, when they occur in a lupus patient, these are generally two disorders that are coincidental, meaning that the ADEM and the neuromyelitis optica is not a direct extension of lupus or Sjogren's, but rather these are two distinct autoimmune disorders. Now, they share certain pathways, and that's why the treatments that are useful for neuromyelitis optica can be used for lupus and vice versa. But really, they do not share a overlapping cause. So to be brief, lupus is not a causative disease that directly leads to neuromyelitis optica. So these neurological disorders are not a direct manifestation of lupus or Sjogren's. They present in a coincidental fashion, and the reason why it's not unusual for a patient with one autoimmune disease to develop another autoimmune disease. So the same way that a patient with neuromyelitis optica has a higher risk, for example, of autoimmune thyroid disease, Hashimoto's thyroiditis, that's why patients with lupus or Sjogren's, they had a higher risk of developing these neurological disorders. But that doesn't mean that they're directly causative. So again, they are coincidental. There is a higher rate of these disorders co-occurring, but there really is it needs to be a reformulation that these neurological disorders such as ADEM, neuromyelitis optica, they're not direct manifestations of rheumatological disease.
Thank you. That's a good point. Dr. Birnbaum, I'll stay with you for this next question. It's a little bit more granular. A lot of the rheumatic conditions we've been referencing are lupus and others. But there's a question that came in about a TM attack that was thought to be a part of Sjogren's syndrome. And the question is how do you look for the onset of Sjogren's besides high ANA blood levels? So other than blood work, how do you really look for Sjogren's in particular in patients? And if somebody comes to you with a transverse myelitis, at what point do you start going deeper than a blood work kind of diagnostics to rule out things like Sjogren's disease?
So Sjogren's could be challenging to diagnose, and sometimes the mean onset between the symptoms of dry eyes and dry mouth and the diagnosis can be 10 years. It used to be about 10 years, and now with greater recognition of Sjogren's, that's back down to 5 years. The symptoms of dry eyes, dry mouth can be elusive in the beginning, so if you ask specifically for dry eyes and dry mouth, you might have an answer suggestive that there's no underlying what we call sicca symptoms, but you have to probe a little bit deeper. So not just asking for dry eyes, but can you wear contacts, and do you use artificial tears? When you ask for dry mouth, you want to specifically on the examination look under the tongue and see whether there's what we call saliva pooling there, which it should be, or whether the mouth is dry. So the symptoms of dry eyes, dry mouth, that might become obvious after years. They could be somewhat subtle in the beginning. We want to have tests which prove that the eyes are dry, and these are generally not done widely in ophthalmology offices, and they probably should be. And there's tests such as taking out a tear strip and seeing how wet the tear strip becomes, and you actually measure this when you put it in the corner of the eyes, and you could see how much moisture wicks out. And again, we want to have cardinal serological features, blood markers, and these tend to be certain antibodies such as called anti-Rho and anti-Li antibodies. If these antibodies are negative and there's a high suspicion for Sjogren's, then we do a lip biopsy, and this is looking for characteristic findings in ducts of certain patterns of inflammation. So if you take that workup together, it could be laborious sometimes, and how detailed the workup needs to be depends upon how much the symptoms crop up at the beginning. So again, Sjogren's could be under-recognized, and a lot of times these symptoms of dry eyes, dry mouth are somewhat marginalized, and they're not thought to be, for example, as worthy of attention as the severe heart-lung disease that occurs in lupus. But these symptoms can be quite distressing, and I think Sjogren's is being raised to be more on the radar screen of everybody. And I think pretty much what Dr. Cho says is I totally agree. When you have someone with a myelitis antedating or coming before Sjogren's syndrome, you want to be more specific about what the nature of that myelitis attack is. So again, like he said, it's, are we dealing with a partial myelitis? Are we dealing with something that might be on the spectrum of multiple sclerosis, or, and especially I agree, when we do see a Sjogren's patient, we're very, very suspicious for neuromyelitis optica popping up. But again, these are disorders that tend to co-occur because they're both autoimmune diseases that share certain features, what we call the antibodies are being churned out. But at the end of the day, you want to precisely categorize what the nature and type of the myelitis attack presented as. But again, if it is, for example, neuromyelitis optica, it should be regarded as a coincidental disease co-occurring, but it's not a direct manifestation of Sjogren's. So again, just to summarize, the diagnosis of Sjogren's needs to be worked up in detail, and what Dr. Cho says, the myelitis needs to be categorized, and ultimately, even if it is neuromyelitis optica, it's going to prove not to be directly caused by Sjogren's.
Mm-hmm. Dr. Cho, do you have...
Cho, yeah, I would love to. I'm glad Dr. Birnbaum reemphasized that. I was going to echo what he said about neuromyelitis optica being an additional disease that is causing the myelitis in these cases that happens to occur in someone who also has Sjogren's. So getting back to the question as it was framed, I guess I don't routinely look for Sjogren's syndrome in someone who has a longitudinal myelitis as the cause for that myelitis. But there are certain forms of symptoms, like in particular, if it's sensory-only symptoms that sometimes can imitate a myelitis. The dorsal root ganglia, the nerve cells just outside the spinal cord that control sensation, can sometimes be affected by Sjogren's syndrome, and that's a very specific syndrome for Sjogren's that would make me look hard for it, even in someone who never had dry eyes or dry mouth or the other symptoms. So I think Dr. Birnbaum's point is, I agree with completely that, 15 years ago, when someone had myelitis, looking for Sjogren's was part of the workup when we thought Sjogren's was causing the myelitis. What we now know is that almost all of those cases where someone ended up with myelitis and Sjogren's was because they had NMO in addition to their Sjogren's. And so it's rare that someone has what would be termed a Sjogren's myelitis without NMO. And there are very few things in medicine that are 100%. So it's not that it's impossible, but I think that most neurologists who deal with myelitis now would assume that the two are co-occurring rather than being caused by the Sjogren's.
It's an interesting point, Dr. Cho. As we get into the last 10 to 15 minutes, there's one kind of group of questions that came in that are more about symptomatic management, really specifically about pain and sensation changes. Often we see that with transverse myelitis, whether it be in the context of an idiopathic event or NMOSD, but we also see pain and sensation changes with different rheumatologic conditions, as you all have been discussing. So the questions have come in really asking, are there any practical suggestions regarding pain management, since this is a big challenge with just singularly with these disorders on their own, but then if you combine them together, that potentially have different reasons why the pain exists. Do you all as clinicians have practical advice on how to manage the pain, whether it be through pharmaceutical interventions, physical therapy, other kinds of pain management that you work with? Dr. Cho, would you like to start off answering that question?
Sure. It's a good and tough question. I think my short answer is that we have a sort of limited arsenal for neuropathic pain that all physicians turn to the same list, and those are not generally as effective for inflammatory pain in other structures outside the nervous system as are seen in rheumatologic disorders. There are some patients who have vague rheumatologic symptoms that are not necessarily directly due to inflammation. Some of those patients may have some relief in their sort of general body aches and pains with medications that we often use for nerve pain, in particular the tricyclic antidepressants like nortriptyline or amitriptyline, or the other category that we often use are the gabapentin and pregabalin. But in general, I would say that you probably have to treat the nature of the pain depending on whether it is specifically affecting the nerves or the spinal cord, somewhat independently from the rheumatologic symptoms. But I would defer to Dr. Birnbaum on the symptomatic treatment for the type of pain that is seen more often in lupus and rheumatoid arthritis and other rheumatologic autoimmune conditions.
Yeah, no, I agree. It could be a very, very tough issue to manage. The interesting thing is when we see rheumatic diseases like lupus or Sjogren's, they could develop very debilitating sensory neuropathies, and these neuropathies can have a predilection for attacking very, very tiny nerves, and it causes a small fiber neuropathy. And certain features of small fiber neuropathies are similar to myelopathy, so it's pain that can be diffuse in nature and can be refractory or not responding to one medication. So a lot of the medications that we use for neuropathic pain are also used in seizure disorders. So the treatment paradigm in seizure disorders that may have relevance for neuropathic pain is the mantra of treat towards efficacy or toxicity. And when you treat neuropathic pain under that paradigm, there's an explicit awareness at the outset that hopefully when you ramp up the dosage, there'll be relief of pain, but there very well may be the experience of unpleasant side effects. But that's the therapeutic window between success and treatment side effects is very, very narrow in neuropathic pain, and I think that needs to be stated at the outset. So what we tend to see is patients treated with neuropathic pain who do not have dosages which are high enough to treat and provide some efficacy. Now, oftentimes these treatments are not tolerated because of side effects, but again, you want to commit to a treatment and you want to ride that treatment wave until there's some demonstration of success. And then the other thing is that often is not due is the combination of treatments for neuropathic pain, and that's polypharmacy. So sometimes polypharmacy, more than one medication, gets a bad rap, and that's true if there's no rational design for why you're using polypharmacy. But when it comes to neuropathic pain, if you combine symptomatic treatments and each of those medications have different mechanisms of action, then there's a rational use of these medications, and polypharmacy is actually the way to go. So, by and large, you can mix and match treatment for neuropathic pain depending upon mechanisms and depending upon what patients are saying. But I think that often when it comes to neuropathic pain, the dosages have been too low, and there's not a commitment towards using two agents. Often you try one agent, and if it doesn't use, you drop it. And again, that's not to say this is going to be a panacea for all patients, but hopefully that will provide a window so that there is some alleviation of pain.
Very interesting. Thank you both for that. In the last 5 minutes or so of the podcast, I wanted to turn it over to Dr. Birnbaum and Dr. Cho to kind of give us their kind of rounding out final thoughts, takeaways for the conversation today, specifically for those members of our community who have these dual diagnoses of transverse myelitis or NMO and a rheumatologic condition, and things to think about, things to keep in your arsenal as you're working with your healthcare team, questions to have in mind. And so if I can start with you, Dr. Cho, any final thoughts or takeaways you have from the conversation today?
Yes, I think that Dr. Birnbaum is a good example of why you need good communication between your neurologist and rheumatologist. So he can just talk to himself, but for everyone else in the country, if you have a rheumatologist for your rheumatologic autoimmune disorder, you still need a neurologist if you have neurological symptoms, and in particular if you have transverse myelitis. And it is not straightforward how those interact. And so you can see even on the same questions, Dr. Birnbaum and I have slightly different perspectives, even though we have a lot of overlap. just by the nature of our training and the types of patients that we see most often and the types of medicines that we use routinely. So I think it's essential to have concerted care with experts who talk to each other, and it is always good to ask those experts about any new symptoms that you have, whether it could if it's neurologic, whether it could be any recurrence of your myelitis, and then asking the rheumatologist whether the neurologic symptoms could be related to the rheumatologic disease, and then again on the treatment side to ask each physician whether the treatment that you're getting for the one condition may have any impact on the other condition.
Dr. Birnbaum, your thoughts?
I totally agree. I think that communication between neurologists and rheumatologists is absolutely essential. One of the things that honestly drives me crazy is if a patient has seen a neurologist or rheumatologist that has a very, very complicated disease course and a lot of different therapeutic options, and she comes to me, or even on follow-up, she says, well, my doctor says to tell me why I should try treatment A or B or C. And that's not fair to you, because you're already dealing with a complex illness, and then to encumber you to be the primary person who acts as a physician is really not fair. So the physician neurologist conversation should happen with other physicians, and you should be involved, but you shouldn't be a sounding board and in the place of direct contact between neurologists and rheumatologists. So I agree, and I see just too often patients being put in the way and having to deal with that, and I don't think that's fair. The other thing I will say is that I would very, very, it's not often, but be careful about if you have a diagnosis of an inflammatory neurological disorder, when you have a new diagnosis of rheumatological disorder pops up, be very, very careful, because a lot of these so-called antibodies, these blood markers that are thought to be somewhat specific for rheumatic disorders, they can occur in neurological disorders. So having a antibody blood marker that could be seen in lupus or Sjogren's is not sufficient. You need to have the signs and the symptoms. So I would tread very, very carefully and really make sure that you have a rheumatologist that you trust. If you're presenting with a new diagnosis of rheumatic disease, make sure that it's an actual disease defined by symptoms and examination findings, and not just a blood marker, because sometimes the rheumatic disease diagnosis can be quite questionable. So really have that diagnosis fully, have that discussion fully with your rheumatologist.
Thank you. That is an important point. And like you both said, as we know so much in all of our lives, communication is key. And I hear so much from patients. A lot of times what they have to be when they have multiple physicians is basically the communication liaison between them. And so it's important to be sensitive to that. I agree with that as well. So to finish off our podcast today, I want to thank you both, Dr. Birnbaum and Dr. Cho, for your time and your expertise sharing that with the community today. Thank you to everybody who sent in questions and is listening out there, and all the members of the community who participate in this. We appreciate your time as well. Be looking forward to the next podcast at the beginning of 2018. And until then, I hope everybody has a happy holiday season and happy New Year. And everybody has a great week as well. Thank you all very much.